welcome to ultrasound. What we're going to cover is just an introduction to ultrasound. I know not all of you will like ultrasound and want to do ultrasound in the future. However, all of you will come across ultrasound reports and ultrasound images. So hopefully this introduction will help you understand some of the terminology that's used within ultrasound and maybe be able to look at some images and see what is actually abnormal on the image. So we're going to start with the basic introduction. You may already know a lot of this from physics, however we're just going to refresh to start with. Now, ultrasound uses a sound wave. It's just like our voice, only it's at a higher frequency than what we can actually hear. So the machine sends out a pulse of sound and then waits for the sound to come back, as therefore the echo. It knows the properties of the sound that it's sent out. It then compares that with the properties of the echo that returns and then creates an image for us. So ultrasound, because it uses sound, is termed non-ionizing. So unlike an X-ray, it doesn't have the ability to knock the orbiting electrons out of their orbit. So it's a non-ionizing form of imaging. And it uses what's called a pulse echo technique, which just means that it sends out a pulse of sound and then listens for that sound or that echo to come back to it and creates the image from the echo. Now, to actually get the sound into the body, we need to use what they call a gel between the transducer and the body tissue. If we don't do that, the sound will actually scatter at the surface of the tissue. So the gel, it allows us to move nice and smoothly over the body tissue as well, and it will also allow then the sound to get into the body and the echo to return. So without it, without the gel and without sufficient gel, you won't actually get an image. The ultrasound image is referred to as a B mode image, the B standing for brightness. So we're talking about brightness mode. And we do look at a scale of grey, so from white down to black, so we get an image which is a scale of grey. So the image is actually a series of dots, and depending where they go on this scale from dark to black to white, depends on how strong the echo comes back to the transducer from the body. So if we've got a bright dot or a bright structure on the image, it means that that structure has sent back a strong echo, reflected the sound well, and we're getting a strong echo back to the transducer. So the image will, that structure on the image will look brighter and more towards the white end of the scale. Now, if we've got a darker structure on our image, it means that it hasn't reflected the sound back to the transducer as strongly. It's a weaker signal, and therefore it will be a darker or more towards the black end of the scale on our image. So looking at this B mode image here, is it actually a picture of the bladder? So B is sitting within the bladder, just here. Now, bladder is filled with fluid, and then we've got our structure down here. So we can see that structure A is white or brighter, so therefore sending back a stronger signal to the transducer, where structure B, the fluid-filled bladder, is sending back a weaker signal to the transducer. Now then we have to look at, well, how does the machine know where to put a structure on the image? And that is all in relation to the time that it's taken for the echo to return. So if we send out a pulse of sound and then we're sitting listening for it to come back, if it comes back quickly, we're going to put it up here where C is. Okay, so this sound has come down and gone back to our transducer, which would be sitting just up the top of the image here. It's gone down and come back quickly, so therefore structure C has to be closer to the transducer and put at the top of the image. If we look at structure D down here, which is actually the prostate, this is a male bladder, so the prostate sitting under the bladder. Structure D, the echo has come down and gone, the sound wave has come down and the echo's come back. That one has taken a lot longer to return than the echo from structure C. So the body goes, okay, so that bit of anatomy is actually deeper in the body, further down from the surface, and therefore put deeper on our image. So just remember, B mode is brightness mode. A brighter, whiter structure sends back a stronger echo. A darker structure has sent back a weak echo. If the echo has come back to the transducer quickly, it will be put more to the top of the screen or top of the image. If the echo has taken longer to return, then the structure will be put deeper in the image or down the bottom. Now in physics, you've probably also learnt and heard about Doppler. And Doppler can be very confusing from the physics side to understand, but what I'm going to explain here is how we actually use it, and we use it mostly to interpret blood flow within vessels. And Doppler is actually a phenomenon that we encounter on a regular basis in general life, but we don't realise it. And probably in physics they gave you the example that if you're standing still on the side of the road and an ambulance is coming towards you, as the ambulance gets closer to you, the siren and the sound of its siren gets louder. Sometimes it can be unbearable, but then if you don't move and it passes you and disappears, the sound will actually disappear and isn't as loud as it goes away. Now, we know the siren on the ambulance isn't changing. The siren is exactly the same. It's coming out at exactly the same frequency or exactly the same loudness. But what's happening is, because we're standing still but the ambulance is moving, we're perceiving a change in the frequency. And that perceived change in frequency is referred to as the Doppler effect. So as I said, in ultrasound, what we use Doppler for is mostly to look at blood flow within the vessels. So this time our transducer is standing still, but what's moving are the red blood cells within the vessels. And so they move in relation to the transducer, so the transducer picks up a perceived change in movement in these red blood cells, and therefore we're picking up the Doppler effect or the Doppler shift. And as we know, the machine knows the frequency of the sound that it's sending out. It calculates the frequency of the sound that it's receiving back in the echo. So it can actually calculate for us this Doppler shift and therefore put it onto our B mode image and give us detail about the blood flow, about the red blood cell movement within these vessels. So we can actually therefore calculate how fast these red blood cells are moving. So we use it in ultrasound in two ways. So we're going to talk about pulsed wave Doppler and colour Doppler. So we do have two types of Doppler, and I suppose it's two different ways of applying this Doppler calculation to our ultrasound B mode images. So we're going to look at the pulse wave Doppler first. So here's an image. The black just in here is a vessel. So the red blood cells are flowing through here. And what we actually do is on the machine, we just hit pulse wave Doppler, and the machine puts this line on, and this is referred to as the gate. And this gate can be narrowed or widened. And the idea is that you put this gate within the blood vessel or the vessel that you actually want to know how fast the blood is flowing. And then once you've got it in position, you then hit the button again on the machine and you get this graph which traces the movement of the red blood cells. So what we have over the horizontal axis here is time, okay, as say the heart's beating away and those red blood cells are moving, and up on the vertical axis here is our frequency. So how fast these red blood cells are actually moving. So this is a typical what we call arterial phase so lets us know we're looking at an artery. So as the heart contracts, we get a pulse of blood, and then as the heart relaxes, we still get a little bit of forward flow of blood, but as the heart relaxes, we only get a little bit, and then the heart contracts again, and so we get that pulse and relaxes. So this is a typical arterial pulse of blood. So what we can actually look at is how fast the blood in this vessel is moving at its peak and at sort of the trough, and give us an idea whether the blood within this vessel is actually normal or not. So this actually gives us, the other thing this could be really good for is comparing how things change over time, because we're actually getting a figure, a number that we can then get, say, the person back in 6 months' time and see if the numbers are the same or they have changed. So it does give us a variable from which we can use for comparisons. Now, the other Doppler that we use a lot as well is what we call colour Doppler. And in colour Doppler, often what we're looking for is there flow within the vessel and what direction the flow is in. And then often then you can still put your gate and get your pulsed wave and your trace if you want to. So this red area here is the vessel, and then the colour denotes the movement. And what you'll see on the side here, all of these, is we have a colour scale. Now these colour scales can be changed. We're very used to using red and blue, and we're very used to, in medical terms, going, okay, so red's oxygenated blood and blue is deoxygenated blood. So your red's your artery, your blue's your vein. Now that in ultrasound can get a little bit tricky, and sometimes it's the reason people don't use red and blue. They might use, say, yellow to green or something like that, because what this is actually showing is flow towards the transducer and flow away from the transducer. So any flow towards the transducer is going to be red, and the faster the flow, the more yellow it becomes. Any flow away from the transducer is going to be blue, and the faster it's moving away, it's going to come into slight sort of tealy greeny colour. So if we look at our vessel here, what we'll notice is it's quite red, so the blood vessels are moving slower on the outside, and then it's nearly to the yellow on the centre, so when blood vessels are moving faster in the middle. Now that is what we expect to see, because the walls of the blood vessel actually provide resistance to the red blood cells movement, and that will slow them down. So we expect those in the center to move faster than the red blood cells on the outside that are getting a bit squashed and a bit caught up on the walls of the vessel. So it does give some information about how the blood vessels are moving and the speed as well, but it also lets us show that we do have flow happening. But just always remember, it's flow in relation to the transducer, so where the transducer is standing on the body. Now, our transducers, there's lots of them. They're very expensive and they're very fragile. There's something that you don't want to go knocking, hitting, dropping on the ground, because they have very fine crystals inside them, and it's very easy for these crystals to move out of alignment, and if they do that, then we don't get a proper image. So they are something that we have to be very gentle and careful of and store nicely, particularly if we've got a lot of them. So we're going to talk about the two main types of transducers, but just be aware that there are a lot more. And it really depends where you're working and what type of work is being done on that ultrasound machine as to what transducers they will have actually purchased and will be sitting in the room. So the transducer is really the worker. It's the thing that sends out the sound and listens for the echo and detects the echo coming back. And as I said, it's got tiny little crystals inside of it. So because of this, in physics, again, you've probably already heard of the piezoelectric effect. So these crystals have this special property that allows them to expand and contract. And as they expand and contract, they give out a sound wave. And conversely, if we apply a sound wave to them, it'll cause it to expand and contract, and therefore we can read off a voltage. So it allows them, therefore, to send out the sound and also to receive the echo that's coming back. So this, in terms of energy conversion, is referred to as electromechanical conversion. So they're changing an electrical energy into mechanical or movement energy, and vice versa. So just remember that that's what the crystals are doing. So they're very fine, very sensitive, and as I said, you have to be very careful that you don't go dropping the transducers, because the crystals can move or can break. Now, what we also have to remember about a sound wave is this property called attenuation. Now, that just means that as the sound goes through the tissue, it's going to get absorbed, scattered and absorbed and reflected by the tissue that it's moving through. And the reflected part is great, because that goes back to our transducer as the echo, and it gets detected. That which is scattered off in all different directions gets lost, and that which is absorbed by the tissue gets lost also. And you've probably heard that ultrasound's main bioeffect is heating. So as the sound goes through the tissue and is absorbed by the tissue, it actually heats the tissue. But all the studies say that ultrasound is safe in what they call perfused tissue. So in tissue where you've got blood flow going through and refreshing the area over, it will dissipate the heat. So they have caused effects in tissue, heating effects and damage in tissue that isn't perfused, but in our general bodies where the blood's coming through and dissipating the heat as it flows through, we don't have any biological side effects. Now, what this means for us scanning is that not every sound frequency, we can't use one frequency to image the body because of attenuation. So we have to change our transducers, change the frequency of our transducers to look at different structures. So this is limited by the depth. So we want to use the most appropriate frequency to image the depth in the body that we need to see. And if I need to see deeper into the body, then I need to actually change the frequency of the transducer. Now, how this works is as we increase the transducer frequency, so as the frequency number increases on the transducer, so if we go from a 3 megahertz transducer to a 5 megahertz transducer, what we're doing with the higher frequency is it will be attenuated more by the body tissue. So therefore your 5 megahertz transducer will not penetrate as deep into the body and give us an image as deep into the body as our 3 megahertz transducer. But what our 5 megahertz transducer does is it gives us better detail. So this is always a trade-off, detail versus depth of image. So we want to use the lowest possible number frequency transducer to give us the depth that we need to see and therefore the best image. But sometimes we have to actually compromise image detail for depth. If I'm scanning the liver, I can't say the liver is clear if I haven't seen it all the way from anterior to posterior. Alright, so if I'm scanning the liver with a 5 megahertz transducer, I'm going to get beautiful detail of the liver superficially, but I'm not going to see it deeper. I'm going to see it right to the back posteriorly. So therefore I need to change to my 3 megahertz transducer to image the liver and see it all. Now, why are we having to make these changes? It's because the body is attenuating the ultrasound, the sound wave. It's being absorbed, some of it's being scattered, not all of it is being transmitted and sent back as the echo. Now, we're going to talk about the two main types of transducers that you're going to find on pretty much all machines. The first one is your linear transducer. Now with your linear transducer, you have a rectangular flat face, just here. It gives out a rectangular field of view, so all the crystals are aligned along this rectangular face and they give out the sound wave. And so this is an idea of an image that you would get. You get a very rectangular image. These transducers are really good for looking at superficial structures within the body. So if I was to look at, say, my thyroid, if we're going to look at musculoskeletal things like shoulders, elbows, ankles, if we were going to look at things like breasts and testes, all those sort of superficial structures in the body, we can use this linear transducer and it will give us a lovely picture. The next thing we then have to decide is what frequency. Now, transducers these days are what we call multi-frequency transducers. In that, one transducer will work at multiple frequencies. So we will still refer to them as one number, and that's usually the middle frequency, but our 7 megahertz transducer might work at, say, 5 megahertz, 7 megahertz and 9 megahertz, and by changing a button on the ultrasound machines we can change the frequency of the transducer. So then we have the 12 megahertz transducer, remembering that the higher the number, the 12 megahertz, the higher the number, the better the detail of our image, but the shallower into the body that we can image. So our 12 megahertz might work at 10, 12 and 15 megahertz. So we want to, wherever possible, when we're scanning things, ideally we want to use our 12 megahertz. And if we were doing say the thyroid, that would be fine. A lot of shoulders, that would be fine. But there are some shoulders where we go, we've got the muscle big thick muscles from, say, a weightlifter or someone like that, and you use your 12 megahertz and you're just like, I can't see through the muscle to get to the tendons that are deeper underneath and closer to the bone. So in those people, we have to drop down to the 7 megahertz. We need it to get through the muscles and get the depth so we can even see the tendon, but yes, our image will not be as clear and as detailed. So remember, it's always a trade-off. You want the best detail, but you need the depth. Now, the next most common transducer you kind of come across is a curved transducer. So you can see the difference in this transducer here. Instead of being flat, it does have a curve on it. So it sticks out more anteriorly here and sort of comes around on the sides here. To get this side part in contact, you actually have to push down. You have to push down into the skin and actually make that whole surface of the transducer in contact with the skin. So this time our crystals are on an arc. They're not flat, they're on an arc, and therefore the ultrasound image that we get is what we refer to as divergent. It splays and spreads out. So here's a picture here, anterior surface here where the transducer is sitting, and you can see we're getting a splayed out image. So these are really good in terms of having this sort of splayed wider, what they call field of view. It allows us to look at structures in their entirety more and side by side, which is a little bit limited with your linear transducer. So this divergent beam allows us to do that. So most things that we're going to be looking at that are at depth, so if I'm going to do an abdomen scan, if I'm going to do a pregnancy scan, if I'm going to look at bladders, livers, pancreases, kidneys, anything like that, I'm going to need to use my curved transducer. Okay, don't even think of looking at the linear one, I just jump straight to my curved transducer. Now again, these transducers will be what we call multi-frequency, so they'll work at multiple frequencies, but one will be around the 3 megahertz, it might work at 2, 3 and 4 megahertz, and then there'll be one that will be at 5 megahertz, which might work at 4, 5 and 7 megahertz. If I was to do an abdomen on a child, I would be able to use my 5 megahertz transducer, all right, because I wouldn't need as much depth, but I would like the extra detail. However, on any adult, I'm going to need to use the 3 megahertz transducer to get the depth. And as I say, if you think about yourself anterior to posterior, if I want to scan the liver, which takes up the whole of your right upper quadrant of your abdomen, to get from the front to the back, we need the 3 megahertz transducer. In a 5 in an adult, you just won't see to the back of the liver. If you're not seeing it well, you could miss a pathology. So they're the two most common transducers that you're going to come across. Now the next thing we have to look at is image orientation. So when we scan, we all scan the same way. No matter where we are, we all scan the same way because of using this image orientation. So we can look at any image and I can know that's the right side or the left side of the body, or that's the head of the person or the feet of the person. Now on every transducer there's going to be a mark on one of the sides. So you'll see on this one it's got a little bobble which isn't there on the other side. So that's indicating that dominant side of the transducer. Sometimes there'll be a line there, sometimes there'll even be a light there on one side and not the other. So that is your dominant side of your transducer, and when I start scanning I always find this dominant side. It's the first thing I do, and then I work out how to orientate my transducer on my patient. So if I've got my patient lying supine on the bed and I want to look in the transverse plane, side to side, I put that dot on the transducer towards the patient's right hand side. And then this will be the orientation on your image. If you think your transducer is sitting here on the tummy, so this is anterior and the sound is going to the back, posterior. This will be the right hand side of the patient, and this will be your left hand side of your patient. Okay, so if you're in the transverse plane, you've pushed that dominant side of the transducer to your patient's right hand side. This is the orientation you're looking at on your image. If I now turn the transducer through 90 degrees and I go into a longitudinal plane, I am going to put the dot always to the patient's head. Okay, so don't put the dot towards the feet, put the dot or the dominant side of the transducer towards the patient's head. Now let's think of our sound wave now. It's still going anterior to posterior from the front skin to the back, so we've still got anterior to posterior on our image, but this time the top of the transducer is superior towards the head and the bottom of the transducer is inferior towards the feet. And these will often be the images when you're looking at them. You want to look at them and you put your head on the side. And when you put your head on your side, you go, oh yeah, okay, I can make that out now. I can see that. That's these longitudinal images. Just remember that dominant side of the transducer goes towards your patient's head. Now, as I said, this is just stock standard routine. All sonographers do this everywhere. And it allows us to look at ultrasound images that anyone's taken from anywhere and have this same orientation. So when you start scanning, every time I pick up a transducer for a new patient to start, I work out the dominant side of the transducer. Now, just to finish off our introduction, we're going to cover, I suppose it's the lingo, the ultrasound lingo or the terminology that we use in sonography. We'll use it when we're describing things. You'll also, the radiologists use it, so you'll find it in reports. So there's funny sort of special little words that are specific to ultrasound. So you do need to know what they are and what they mean. So the terms echogenic and anechoic are opposites. So a structure that we'd say is echogenic is bright on our ultrasound B mode image. It's bright, it's white, it sent a strong echo back to the transducer. So it's referred to as an echogenic structure, a bright white structure. An anechoic structure is dark or black on our image. So these are the structures that are sending back the weak echoes and therefore being denoted as black on our ultrasound images. So fluid-filled structures like the bladder that we've looked at and like the vessel that we were looking at are anechoic, they're black. Now, the next three terms are really describing one structure to another. So if I've got two structures side by side, then I might say structure A is hyperechoic to structure B. So what does that mean? It's brighter. Okay, it's giving back a stronger echo, it's brighter on our image. It's hyperechoic, brighter on our image. Conversely, I could say that structure A is hypoechoic to structure B. This time what I'm saying is that it's darker or blacker than structure B. Okay, so hyperechoic and hypoechoic. Now the little trick I remember to discern between these two is the hypo, the O for low is how I remember it. Hypo, O for low, so it's darker. So a hypoechoic structure is darker, a hyperechoic structure is lighter. Now, what if I've got structures A and B that are the same brightness? So they're either on our grey scale, they're both like bright and white, they're both dark, or they're about the same grey level. One isn't brighter or darker than the other. To us, they look the same. Then the term is isoechoic. They're the same. So I've got two images now, and I'm just going to look at these images using these terms. So this first image is a bladder. So the black area is the fluid-filled bladder, and inside this bladder is a stone. This large thing here is a stone, and then you may remember the artifact from physics of shadowing. In behind that stone we have a shadow, so that lets us know that this is actually a calcium-filled stone, and it's black because none of the sound is getting past this calcium-filled stone. So if I wanted to talk about the bladder, I would say the bladder is anechoic. The stone, however, is echogenic. I could say there is a hyperechoic stone within the bladder. I could say that the bladder is hypoechoic in comparison to the stone. Okay, let's go to the next image. Now, this image is actually of the kidney. So the kidney just here, it's just chopped off there, and this is the bit of the liver, just up this triangle bit up here. And the kidney, you can actually discern between the outer cortex and the inner medulla. And this just here is a cyst sitting in the cortex of the kidney. Okay, so I can say the cyst is anechoic. I can say that the medulla of the kidney is echogenic. If I'm comparing the cortex to the medulla of the kidney, the cortex is hypoechoic to the medulla. The medulla of the kidney is hyperechoic to the cortex. The medulla of the kidney is hyperechoic to the cyst. Now, that is what we expect to see. That is normal in a kidney. Right? If we don't see that, there's something going on, that relationship with the kidney. Now, I want you to look at the liver here and the greyness of the liver, and then the greyness of the cortex of the kidney. They roughly look the same, grey level. And again, that is normal. We expect to see that. So what we say is that the liver is isoechoic to the cortex of the kidney. Okay, it's the same, isoechoic to the cortex of the kidney. And that is what we expect to see in a normal person. So just the words, we'll start to use them, getting used to the terminology and sort of the ultrasound language is important. You will read it on ultrasound reports from both the radiologists and also from sonographers. So a sonographer often doesn't go, oh, there's a cyst. They may do that, and if we're not sure what it is, we might describe it, and we use our words. So there is an anechoic structure sitting within the cortex of, say, the right kidney. And then it's up to the radiologist to work out what that anechoic structure actually is.